Greetings from the United States. My name is William Brady, and I will be talking to you about updates on cardiac arrest management in 2014. I would like to thank Dr. Murat Çetin for his invitation to attend your conference, and I am very sorry that I was unable to attend physically, but hope that this lecture presented from afar will be of some value to you in your management of patients experiencing cardiac arrest. As I said, my name is William Brady. I'm a professor of emergency medicine at the University of Virginia in Charlottesville, Virginia. Charlottesville is approximately 120 miles southwest of Washington, D.C. on the east coast of the United States. We are a rather busy emergency department and manage a number of extreme patient presentations, including cardiac arrest, which are not unlike the patients that you manage on a daily basis. In this lecture today, I would like to talk about some of the basic issues that are important for any clinician to be aware of in managing cardiac arrest, as well as touch on new concepts that we need to be aware of in the management of these types of patients. Cardiac arrest can occur in any situation and in any location. In a very general sense, we separate cardiac arrest into three categories: out-of-hospital cardiac arrest occurring in the emergency department, and inpatient or hospitalized patients experiencing cardiac arrest. While all three are different types of patients and patient presentations, the out-of-hospital and emergency department categories have some degree of similarity and can be approached in similar fashion. The out-of-hospital and emergency department patient subgroups, however, are quite different from the inpatient or hospitalized patient experiencing cardiac arrest. In a very general sense, in the out-of-hospital and emergency department settings, cardiogenic cardiac arrest, or cardiac arrest caused by a cardiac cause, is the more common type of presentation. In fact, fully 70% of the cardiac arrest patients managed in these two areas are cardiogenic in nature. This is quite different from the hospitalized patient who experiences cardiac arrest from a range of possibilities, including cardiogenic and non-cardiogenic causes. Again, in a very general sense, cardiogenic cardiac arrest is noted to occur in approximately 50% of hospitalized patients, and of course, the remaining 50% are caused by a range of non-cardiogenic causes, including sepsis, multiple trauma, overdose, multi-organ failure, neurologic illness, etc., etc., etc. The American Heart Association, working in conjunction with the International Liaison Committee on Resuscitation, or ILCOR, have published their guidelines most recently in 2010. In this guideline addressing the management of cardiac arrest, the American Heart Association stresses 5 important goals, which include 3 basic issues, 1 advanced issue, and 1 post-cardiac arrest management issue. It is important to note the emphasis on the basics of management, which include immediate recognition of the event and activation of the emergency response team, early CPR with emphasis on most awesome chest compressions, and rapid defibrillation delivered to those patients with a shockable cardiac arrest rhythm. Of interest, effective advanced life support, meaning the placement of invasive airways, intravenous access, and the use of cardioactive medication, represents only one of these 5 goals. And for the first time, we see significant emphasis being placed on the integration of post-cardiac arrest management, including advanced critical care support, hypothermia, coronary reperfusion, among other management goals in the patient that has been successfully resuscitated. These 5 management goals include rapid team activation. This is considered a critical intervention. When the layperson or the medical person witnesses cardiac arrest, the emergency response team should be summoned. In the out-of-hospital setting, this involves management via the emergency medical services personnel, and for in-hospital events, the cardiac arrest or code team is summoned. The second management goal involves CPR, and of the various interventions included in CPR, chest compressions are very important and again considered a critical intervention. It is stressed that these chest compressions should be high quality, occurring at the appropriate rate with minimal to no interruption. The third goal involves defibrillation, which can be delivered via an automatic external defibrillator or a complex multifunction device. In either case, rapid access to defibrillation for those rhythms that are amenable to a defibrillation is again considered a critical intervention. Of course, these rhythms include pulsus ventricular tachycardia and ventricular fibrillation. The two remaining management goals include the use of advanced life support measures and the application of post-resuscitation care. Advanced life support in guidelines published in the past assumed a much more significant and important role. While this intervention is still considered important, it is not as critical in the early management of cardiac arrest as team activation with recognition of the event, early defibrillation, and effective chest compressions with your CPR. Certainly advanced life support is important and should be used, but please do not forget about the important initial goals that we've already mentioned, which focus on the basic interventions. Advanced life support in this context includes the use of advanced airways, most often an invasive airway, including a supraglottic device or endotracheal tube. Also, intravenous access or intraosseous access through which intravenous fluids and cardioactive medications can be administered. These interventions are important, yet not as critical as the basics. The last of the 5 goals is the use of post-resuscitation care in those patients that have been resuscitated with continued return of spontaneous circulation. These goals include supportive critical care, optimizing perfusion and oxygenation ventilation, as well as the application of induced hypothermia in those patients that are candidates for this intervention, and coronary revascularization in patients experiencing STEMI and other acute coronary events. Again, these 5 goals are very important to address in your patients in cardiac arrest. It is also important to note that the basics in out-of-hospital and ED-based cardiac arrest are very important and must be performed in all resuscitation cases. Advanced life support measures are important, but these are of secondary importance in the first 2 to 4 to 6 minutes of most cardiac arrest events occurring in the out-of-hospital setting and the emergency department. For those patients that are inpatients and patients in any setting who have a non-cardiogenic cardiac arrest, earlier provision of an airway via an invasive means and the use of intravenous or intraosseous medications are certainly important, but even in these non-cardiogenic settings, the basics must be addressed, including activation of the team with recognition of the event and adequate, appropriate chest compressions. In addition to recognize that the basics of resuscitation are critical interventions, we must also realize that bystander care delivered by lay personnel is also crucial. These lay people, these lay providers, the general public, must be schooled in recognition of the problem of cardiac arrest, how to activate the emergency response system in their area, as well as the importance of certain interventions which they can perform safely and appropriately with minimal training. These interventions include appropriate chest compressions and the use of an automatic external defibrillator. We all know that outcome in the setting of cardiac arrest is significantly impacted by the time to appropriate intervention. This graph on the right of the slide demonstrates that time is a very critical determinant in survival, where earlier application of therapy, including chest compressions and defibrillation of those rhythms requiring defibrillation, can significantly improve the chance of survival in patients experiencing cardiac arrest in any location. We must encourage this approach by supporting training and education and empowering and enabling the lay public to approach these patients long before emergency medical services or the hospital-based physicians are involved in the patient's care. In most cases, the outcome is largely determined prior to any formal medical involvement. Recent research has focused on the relative importance of various factors and features in cardiac arrest management in the out-of-hospital setting. These two studies that I've chosen to discuss today with you stress the importance of basic interventions and the importance, but less importance, of the advanced management interventions. On the upper left of your slide, one study which focused on various factors and features and their impact on cardiac arrest outcome stresses this concept that basic is very important. In this study, several different features were considered, including witnessed arrest, bystander CPR, defibrillation, and the application of advanced life support. The results are expressed in terms of odds ratio suggesting survival. We know that an odds ratio greater than 1 suggests that that variable is associated with a positive impact on survival, meaning that this is associated with an increased chance of survival, while an odds ratio less than 1 suggests that that variable is associated with a reduced chance of survival in the cardiac arrest patient. An odds ratio of 1 suggests that this variable has neither a positive nor negative impact on outcome. I've chosen 4 different variables to discuss with you from this study. First and foremost, having a witnessed cardiac arrest by anyone is associated with a better chance of survival with an odds ratio of 4.4. Having any form of bystander CPR, whether it includes compressions or compressions with ventilations prior to emergency medical services or other medical personnel arrival, is again associated with a increased chance of survival with an odds ratio here of 3.7. Defibrillation occurring less than 8 minutes is again associated with an increased chance of survival, and subgroup analysis in this category suggests that defibrillation occurring less than 6, less than 4, less than 2 minutes is even more strongly associated with survival. Interestingly, advanced life support, which includes the use of invasive airways, intravenous or intraosseous access, and the use of cardioactive medications, is weakly associated with survival in cardiac arrest with an odds ratio of only 1.1. The study in the lower right of your slide further explores this idea. Early in this study, in the first phase of management, EMS providers approached the cardiac arrest patient with a focus on chest compressions and shocking shockable rhythms early. In other words, attention to the basics and only then using advanced interventions after the basics had been appropriately addressed in the first several minutes of resuscitation. The second phase, or later portion of the trial, focused on the standard advanced cardiac life support approach to cardiac arrest management, which included earlier use of advanced invasive airways, cardioactive medications, as well as chest compressions and defibrillation for those patients that warranted defibrillation. If you look at the survival curve, you see that it is the same or quite similar in both phases. Phase 1 focusing on the basics, and Phase 2 using advanced. So taking these two studies and other studies that have been performed in the past 10 years, I think it is very important for us to all realize that the basics are very important and have high impact and are critical in terms of their ability to promote survival, while advanced life support with invasive airways and medications is positive and is no way negative, but has a much less positive impact on survival in the cardiac arrest patient. As noted previously, activation of the emergency response team will allow the patient to receive care at an earlier period. This care, whether delivered by professional or lay personnel, must be delivered as early as possible. We do know and are very much aware of the time-sensitive nature, the critical time-sensitive nature of cardiac arrest management and its impact on survival. This graph demonstrates that the probability of survival is only 40 to 45% in patients that are almost immediately attended to in the setting of cardiac arrest, and the probability of survival rapidly drops off and approaches zero beyond 12 minutes. After activation of the emergency response system, the next most important goal is the performance of cardiopulmonary resuscitation. This is a key intervention that should be started by lay personnel prior to professional medical assistance. Cardiopulmonary resuscitation, or CPR, has two basic components: chest compressions and ventilations. When one considers cardiogenic cardiac arrest, the value of the two interventions must be discussed. In this setting of cardiogenic cardiac arrest, occurring in any setting, compressions are likely of significantly more value than ventilations, particularly early in the resuscitation. By early, I mean somewhere in the first 2 to 8 minutes of resuscitation event. In the setting of non-cardiogenic cardiac arrest, compressions are still very important, but ventilations may have a larger role early in the management of cardiac arrest. Remember, in the out-of-hospital and emergency department settings, we likely encounter most patients with cardiac arrest occurring from a cardiogenic cause, while in the inpatient setting, we have a higher rate of non-cardiogenic cardiac arrest, such that both entities occur with equal frequency. In the setting of cardiogenic cardiac arrest, these patients have been well until the sudden development of cardiac arrest. By meaning well, these patients were likely appropriately oxygenated and ventilated by themselves immediately up to the cardiac arrest. Thus, no significant oxygen debt exists until the first several minutes of cardiac arrest has passed. Furthermore, the acid-base status of these patients in the first several minutes after cardiac arrest is not particularly problematic. The exact opposite, in fact, is true in patients with non-cardiogenic cardiac arrest. These patients have been unwell for many minutes, to many hours, to many days, and sometimes to many weeks and many months and many years prior to the onset of cardiac arrest. By being unwell for this longer period of time, these patients have likely experienced oxygen and ventilation problems such that they are not well oxygenated when cardiac arrest occurs, and likely have significant abnormalities in their acid-base status. This is the basis for the significant importance of compressions early on in all cardiac arrests, and the relative less importance of ventilations in cardiogenic cardiac arrest early on versus non-cardiogenic cardiac arrest. In a very general sense, ventilations are of less value in the early phase of cardiogenic cardiac arrest and likely are more important in the early phase of non-cardiogenic cardiac arrest. In both settings, chest compressions adequately and appropriately performed with minimal to no interruption are key. As I've noted, chest compressions are very important and considered critical interventions in the setting of cardiac arrest management, particularly early in cardiac arrest. These chest compressions must be high quality. The rescuer must push hard, deep, and fast. Hard, deep, and fast is the key to performing appropriate chest compressions in cardiac arrest. In the adult patient in cardiac arrest, chest compression depth should be somewhere between 2 to 3 inches. Deeper compression depths eject more blood per compression. This is related and results in improved perfusion, which ultimately is associated with better outcomes in the patient in cardiac arrest. In addition to pushing hard and deep, the compression rate is very important, hence hard, deep, and fast. An appropriate compression rate for an adult in cardiac arrest is 100 compressions per minute. As with compression depth, more rapid rates of compression increase cardiac output, which improves perfusion and is associated with better outcome. Caution is advised, however, in this setting because providing 100 compressions per minute over the first 2, 4, 6, 8, 10, 12 minutes of resuscitation are quite fatiguing. If possible, rescuers should take turns performing chest compressions such that fatigue and inattention do not negatively impact the hard, deep, and fast goal of chest compressions. As we've noted, chest compressions are important. Chest compressions that are high quality are very important. Remember, we need to push hard, deep, and fast. Okay? Another important point about chest compressions is we need to limit interruptions as much as possible. It is very important to attempt to not stop in your chest compressions during cardiac arrest, except for the most important periods of analysis and other procedural intervention. This slide depicts chest compressions being formed in a typical resuscitation with several different interruptions occurring and the very significant impact on perfusion. Each of these small undulations is produced by one chest compression. Each succeeding chest compression produces more forward flow of blood through the body. As these chest compressions occur in sequential fashion, forward flow is augmented further and further and further, such that a near adequate perfusion pressure can be reached. But once compressions halt, all perfusion stops, and it does require a considerable period of time of sequential chest compression performance for an adequate and appropriate perfusion pressure to be once again attained. Each one of these interruptions halts all perfusion, and it takes a reasonably long period of time for appropriate perfusion to once again be experienced by the brain and the heart and the rest of the body after resumption of chest compressions. Therefore, we need to limit interruptions in chest compression performance as much as possible. This slide depicts a more optimum performance of chest compressions with minimal interruptions. As we noted in the previous slide, each successive chest compression, indicated by an undulation in this waveform, produces and augments cardiac output and appropriate perfusion. Each successive compression produces further flow of blood such that ultimately a near appropriate, if not appropriate, perfusion pressure can be reached that is experienced by the brain, the heart, and the rest of the body. In this particular slide, several sequential chest compressions have produced adequate forward flow, and ongoing chest compressions sustain this appropriate flow. Recent literature has begun to explore the concept of chest compression fraction. Chest compression fraction is defined as the total amount of time that chest compressions are being performed during a cardiac arrest resuscitation divided by the total time of the resuscitation event itself. In other words, how much time are chest compressions being performed during a cardiac arrest resuscitation? This is just another way of stating that chest compressions are important, and interruptions and limitations in continuous chest compressions are negatively associated with survival. This has been demonstrated in both ventricular fibrillation or shockable rhythm patients, as well as non-VF VT patients or the non-shockable patients. In both studies here, we see that higher chest compression fractions, which means that more chest compressions are being performed during cardiac arrest, are associated with a better chance of survival. This is seen in all patients in cardiac arrest. Several important time factors must be mentioned in the concept of chest compression performance and interruptions. The first, and probably most important, is for each 10 seconds of no compression performance, during a cardiac arrest resuscitation, survival is reduced by 5%. Each 10 seconds of no compression time reduces survival by 5%. The second important point is that the resumption of CNS perfusion, the blood flow experienced by the brain after the resumption or restarting of chest compressions, requires 40 to 45 seconds to reach an adequate to near adequate perfusion pressure. In other words, once the rescuer resumes the performance of chest compressions, it takes another 40 to 45 seconds for appropriate perfusion to reach the level of the brain. With the recognition of the significant and extreme importance of appropriate chest compressions, many people have re-explored the concept of mechanical CPR devices. These devices broadly are separated into two categories: the piston device or the band-like compression device. In both cases, these devices are driven by either electrical power, using wall outlets from the location in which the cardiac arrest is being managed, or unit-based battery power. Conversely, the device can also be driven pneumatically using gas, whether it be compressed air or compressed oxygen. In either case, these devices are quite portable and can be taken into the scene of a cardiac arrest management or used in a hospital environment. These devices have been around for many years, but renewed interest has occurred with the recognition of the extreme importance of chest compressions and its impact on survival in cardiac arrest. Multiple studies have been done and are being done looking at mechanical CPR devices in the hospitalized and out-of-hospital patient in cardiac arrest. Surprisingly, these studies have noted either equivocal or minimally positive results. It is important to note that no study has demonstrated harm or negative outcome in the setting of appropriately applied mechanical CPR devices. These studies that have been done are either small in number of participants or have significant methodologic issues that reduce their impact on management decisions. Current studies are ongoing, and we must await the results of these studies to decide what the most appropriate use of these devices are in an evidence-based fashion. For now, I recommend using them in personnel-limited environments. In the out-of-hospital setting, where you may have 1, 2, or 3 EMS providers providing care for a cardiac arrest patient, these devices can be quite helpful and can allow the providers to focus on other issues while the machine performs appropriate chest compressions. The same can be said in the hospitalized patient, where the number of personnel may be limited or few, and the same issues would apply. We will now discuss defibrillation of pulseless ventricular tachycardia and ventricular fibrillation using the automatic external defibrillator and the multifunction device. The use of automatic external defibrillators, or AEDs, has markedly improved the outcome of patients with cardiac arrest. This is true in the out-of-hospital setting as well as hospital setting. AEDs, particularly in the out-of-hospital setting, markedly reduce the time to the delivery of the first defibrillatory shock and therefore have had significant impact on improvement in survival. These AEDs can be used by medical personnel, and they can also be very safely used by lay personnel with little to no medical knowledge or training. The use of the AED is quite simple and frankly is less complex than the construction of a home entertainment system. This particular study I've chosen to talk to you about was performed in the Netherlands and looked at the management of out-of-hospital cardiac arrest and the impact of the AED on outcome. They had 2,800 approximate patients with cardiac arrest, and they separated the patients into three categories: AED on-site, meaning the AED was quite close by; AED distant, meaning that it was on-site but rather distant from the patient; and the third category was the standard EMS response with delivery of defibrillatory shock. Looking at the three categories and the time to shock, markedly lower in the AED on-site group with a 4.1 minute average time compared to 8.5 for AED distant and an approximate 11 minute for EMS response. Considering survival, we see a very impressive 50% survival with an odds ratio of 2.7 supporting survival for patients that are managed with an AED close by. Outcome is still favorable in an AED distant with a survival rate of approximately 14% and an odds ratio slightly greater than 1. Considering EMS response, the time to first shock is markedly longer, averaging approximately 11 minutes, with a survival rate here of approximately 5.5%. The use of AEDs by either lay or medical personnel is a very important step in the management of cardiac arrest and can have significant impact on the outcome. As emergency healthcare providers, it is our responsibility to instruct the lay public as well as other medical personnel on both the importance of the AED and the use of the AED in cardiac arrest management. When should we defibrillate our patient in cardiac arrest? Earlier literature suggested that the earliest time or the shortest time to defibrillation was most appropriate. Approximately 5 to 10 years ago, literature then surfaced suggesting that patients that had been in cardiac arrest for greater than 4 or 5 minutes or had an unknown downtime likely would benefit from the performance of chest compressions for approximately 2 minutes, followed by shock if appropriate. The most recent literature suggests that the time to defibrillation is not yet known. This study, which looked at almost 10,000 patients in cardiac arrest, compared early versus late rhythm analysis with subsequent defibrillation as needed. They considered a primary outcome of survival to discharge with intact neurologic status. In this study, they noted no significant difference in survival to discharge with intact neurologic status when one considers the time to shock. So what does the American Heart Association say now? They say that they do not know and suggest that healthcare providers should perform the shock when they feel it is most appropriate. Considering this recommendation, I feel that as soon as possible a defibrillation should be performed. While the AED or multifunction device is being prepared for defibrillation, the patient should be managed with chest compressions and, if possible, airway management. While the AED or multifunction device is being activated, these chest compressions can continue. Once the device is ready to deliver the shock, this can be delivered appropriately. So my basic recommendation is deliver the defibrillatory shock when appropriate as soon as possible after the recognition of a shockable cardiac arrest rhythm. As we are performing chest compressions during cardiac arrest, we must consider those patients that should be defibrillated. As we approach the time to consider the cardiac rhythm, and if needed deliver a defibrillation, we must also consider the negative impact that the pause in chest compressions can produce. As we've noted before, we must limit interruptions and we must reduce the length of interruptions in chest compressions in the patient with cardiac arrest. One important area includes the rhythm analysis and the time to deliver a defibrillation. The most appropriate fashion of doing this suggests that we perform compressions and charge our defibrillator in advance in anticipation of the need for defibrillation. As our 2-minute period of chest compression ends, we halt compressions and analyze the rhythm. If the rhythm is shockable, we rapidly deliver a shock and then resume chest compressions immediately. This is the most appropriate way to approach this issue and is termed the anticipatory charging approach. In this study that I've chosen to discuss with you today, this approach resulted in a very, very short period of chest compression interruption, in this study averaging 3.9 seconds. The other end of the spectrum involves the halted method, where chest compressions are being performed, and as the time to perform defibrillation approaches, chest compressions are stopped, the rhythm is analyzed. If it is a shockable rhythm, the machine is then charged with ultimate subsequent delivery of a shock. As you can imagine, this results in a much longer period of no chest compressions, and in this study, approaching 15 seconds. The difference between the anticipatory charging approach with approximate 4-second interruption in chest compression is quite different from the halted method approach of chest compression interruption approaching 15 seconds. As we noted, for every 10 seconds of no chest compression performance, survival is reduced by 5%. Here, we can certainly improve the odds of survival by using the anticipatory charging technique. An important area that is under development in many centers around the world involves the idea of ECG filtering during active chest compressions. I have two waveforms that I've depicted for you to illustrate this point. The upper waveform demonstrates the unfiltered standard monitoring during cardiac arrest while chest compressions are being formed. The waveform depicted is in fact not a cardiac rhythm, but is a depiction of the motion artifact produced by appropriate chest compressions. In this setting, interpretation of the cardiac rhythm is impossible. Therefore, as the 2-minute period of chest compression ends, we are forced to halt chest compressions, which means all perfusion stops to the brain and heart. Then we can interpret the rhythm and act accordingly. The second or bottom rhythm strip demonstrates the filtered or enhanced monitoring during cardiac arrest and the performance of chest compressions. While the cardiac rhythm depicted is not pure and easily interpreted, it is very clearly a narrow complex rhythm occurring at a rate of approximately 90 to 100 beats per minute. The important point here is being able to distinguish and identify the appearance of either ventricular fibrillation or ventricular tachycardia. Why is this important? If we are able to manage and interpret the cardiac rhythm during active chest compressions, this will reduce another need for chest compression interruption, which I believe I've mentioned to you is bad. Please remain aware and stay tuned to this important development in cardiac arrest management. We will see much more of this in the next 5 to 10 years. Let us now focus on advanced life support. Advanced life support in this meeting indicates invasive airways, the placement of either intravenous or interosseous catheters, and the administration of cardioactive medications. In most, if not all settings, advanced life support is considered an important positive intervention. But its impact, particularly in cardiogenic cardiac arrest, early in resuscitation, is minimal compared to the markedly positive impact of appropriate chest compressions and shockable rhythms. In non-cardiogenic cardiac arrest, the earlier use of advanced life support procedures, as I've indicated before, is likely more important. The use of invasive airways early in cardiac arrest is most often not associated with improved survival rates. This has been demonstrated in the out-of-hospital setting as well as the hospital patient. The use of invasive airways includes both endotracheal intubation as well as the use of the various supraglottic devices. While it is never wrong to provide an airway at any phase in cardiac arrest, it is important if the provider chooses to provide an airway early in cardiac arrest. The application of the airway should not negatively impact or interfere with appropriate chest compression performance and shockable rhythms. Another form of advanced life support involves placement of an IV catheter or, by extension, an intraosseous catheter and the use of the various cardioactive medications. In this study, performed in Norway, we see in the out-of-hospital setting that the odds ratio for survival is not significantly impacted as a function of IV placement or medication use. In fact, the odds ratio predicting survival was 1.15 in those patients receiving IV therapy of whatever type. We have several different types of vasopressors that we can use in bolus fashion in the patient with cardiac arrest, including both vasopressin and epinephrine. Vasopressin has been in use for approximately 15 to 20 years, and when initially released was reported to significantly improve resuscitation rates in cardiac arrest. This is certainly true when you compare it to placebo or other vasopressor agents, but most importantly, the ultimate outcomes are not different. In other words, patients that receive vasopressin compared to other vasopressor approaches do not have a higher rate of ultimate survival or improved neurologic function at the time of discharge. Thus, the ultimate outcome of patients in cardiac arrest is not significantly impacted by vasopressin therapy. The other primary vasopressor used in cardiac arrest is epinephrine. It has been around for many years and has been used in hundreds of thousands, if not millions, of patients in cardiac arrest. Until recently, the literature base supporting its use was very minimal, and those papers that did exist were quite negative. A recent exploration of epinephrine use suggests that in certain patients, used appropriately in conjunction with the other basic and advanced areas of resuscitation, can have a significant impact on survival of cardiac arrest. One paper, in fact, noted a significant improvement of neurointact survival, while other studies have noted minimal to no impact. This area of resuscitation science should be followed closely. In my practice, I continue to use either vasopressin or epinephrine in the appropriate patient in cardiac arrest, but I do not let the use of cardioactive medications delay or interfere with the more basic chest compressions and defibrillation. Another important area of cardioactive medication in cardiac arrest management is the antiarrhythmic agent. Amiodarone has been in clinical use for approximately 10 to 20 years, and like vasopressin, when it was initially released, it reportedly increased the rate of survival in patients with cardiac arrest. But like vasopressin, the ultimate outcome of survival to discharge with intact neurologic status is not significantly impacted when you compare amiodarone to placebo or to lidocaine. So, similar to the bolus dose vasopressors, antiarrhythmic agents likely are not negative in impact and can potentially positively impact patients, but the impact is modest at best, and probably most importantly, their use should not interfere, again, with the more basic important areas of resuscitation medicine during an individual cardiac arrest event. Thus, the use of advanced life support is almost never wrong, and is certainly almost never harmful in the management of patients in cardiac arrest, unless it distracts from other treatments of proven significant impact, such as chest compression and defibrillation of shockable rhythms. The range of cardioactive medications in cardiac arrest have a modest positive impact on survival, and in certain settings, these medications have niche applications. For example, the use of calcium in a hyperkalemic cardiac arrest, or the use of magnesium in a patient with polymorphic ventricular tachycardia likely related to a long QT syndrome. There are other such examples, and the niche application of these medications should be considered. Certainly the use of invasive airways, whether it be an endotracheal tube or a supraglottic device, are also positive, but several comments must be made here. Early in the management of a cardiogenic cardiac arrest, where the oxygen deficit is minimal and the acid-base status is near normal, it is more appropriate to focus on chest compressions and shockable rhythms. If adequate personnel are available and an invasive airway can be placed in this setting without negative interference with the priorities of treatment, then it can be done. Conversely, if adequate personnel are not available, or an invasive airway can't be placed without negatively impacting chest compressions, then early in the setting of a cardiogenic cardiac arrest, the invasive airway should be held. In the non-cardiogenic cardiac arrest, earlier placement of an invasive airway is appropriate and should be considered if possible. The fifth and final goal of management of cardiac arrest focuses on post-resuscitation management. In this setting, we have already resuscitated the patient and are now focusing on providing appropriate critical care as well as certain other important interventions. We will discuss these now. The post-cardiac arrest syndrome is a specific, unique medical syndrome and is obviously encountered after the patient has been resuscitated from cardiac arrest. It is in a natural state in that the natural history of cardiac arrest is death. As healthcare providers intervene and alter the natural history of cardiac arrest, we have a patient that has been resuscitated and is experiencing the post-cardiac arrest syndrome. There are multiple events and issues to consider in this setting, including CNS injury, myocardial dysfunction, systemic ischemia, reperfusion-related injury, and of course, what caused the cardiac arrest, the so-called precipitating pathophysiology considerations. First and foremost, CNS injury involves the sequela of low flow and hypoxic injury on the brain during the cardiac arrest event. It is important to realize that even after restoration of appropriate perfusion and adequate oxygenation in the patient who's been resuscitated from cardiac arrest, ongoing CNS injury can occur for many hours to days after resuscitation. Myocardial dysfunction considers the patient with both STEMI and non-STEMI presentations. This myocardial dysfunction addresses low cardiac output states as well as other cardiac dysfunction and can appear as early as the first several minutes after cardiac arrest resuscitation and continue for many days afterwards. Systemic ischemia is in fact systemic ischemia, resulting from the no-flow period of cardiac arrest management. Reperfusion-related injury addresses the body's immune system and other compensatory and protective measures that occur after the resuscitation event has occurred. This is an important area of cardiac arrest resuscitation that is undergoing rigorous review at this time. And lastly is the precipitating pathophysiology. The post-cardiac arrest management issues are markedly different dependent on what caused the event. Certainly a gunshot wound to the chest that experienced cardiac arrest and has been resuscitated is going to require a very different approach to a patient that has had an obstructed airway causing cardiac arrest that has been resuscitated. This diagram illustrates the most appropriate approach to post-cardiac arrest management in the patient that has been resuscitated. This algorithm is a general algorithm and certainly can be applied and adjusted as needed by the clinician managing the patient. But it can be used in many settings, including the emergency department or in an ambulance on the way to the hospital. After the return of spontaneous circulation or the development of a pulse, that is sustained, the healthcare team must address two issues almost immediately. These include appropriate oxygenation and ventilation and appropriate perfusion. Certainly, oxygenation and ventilation can be maximized by adding supplemental oxygen in someone who is breathing spontaneously. In other situations, this patient may be most appropriately managed with the provision of an invasive airway, such as an endotracheal tube, supporting oxygenation and ventilation. Certainly, perfusion can be optimized by fluid boluses of normal saline. If this is not adequate, and after an appropriate amount has been administered, various vasopressors and inotropic agents can be provided. Also, rhythm management is important at this stage. As these issues are being addressed, then the next two important considerations involve the consideration of induced or therapeutic hypothermia and the application of coronary reperfusion or revascularization therapies. When one considers therapeutic hypothermia, the patient should be unresponsive. If the patient is unresponsive and has been resuscitated from cardiac arrest, they can be considered a candidate for therapeutic hypothermia. We will mention that in the upcoming material. Also, if the patient's experiencing a STEMI or significant other acute coronary syndrome event, coronary reperfusion therapy in the cardiac catheterization laboratory with PCI, or in cases of obvious STEMI, fibrinolysis can be applied. Of course, these issues must be performed while appropriate advanced critical care is simultaneously being applied. As we've noted in the post-resuscitation phase of management of cardiac arrest, one of the primary goals is the provision of appropriate oxygenation and ventilation. In those patients that require supplemental oxygen delivered via a range of means, including face mask and endotracheal tube, we must be cautious and deliver oxygen, but not deliver excessive oxygen. We do know for a fact that hypoxia, or lower oxygen levels, are associated with negative outcome, and it's now been demonstrated that hyperoxia, or excessive amounts of oxygen, are also associated with negative outcome. In this small study of patients resuscitated from cardiac arrest, several interesting trends have been noted. First and foremost, survivors had an average arterial oxygen content markedly lower than non-survivors. Also, higher arterial oxygen levels were significantly associated with increased hospital mortality and an increased chance of poor neurologic status at discharge. I have taken this information and others and changed my approach to managing oxygen therapy. In the past, I would always attempt to maximize the arterial oxygen status and drive for oxygen saturations of 100%. Now, in patients that I am using supplemental oxygen in the management of the post-resuscitation period, I now aim for saturations somewhere between 95 to 98%. If I have a saturation of 100% in the setting of supplemental oxygen, I will reduce the amount of oxygen I am giving. I do not want to have 100% saturation. I am aiming for somewhere between 95 to 98% saturation. This is an example of too much is not good. Induced or therapeutic hypothermia is a very important intervention. This study is a meta-analysis that considers 4 randomized studies. They have reported the results with the concept of number needed to treat, and they report very promising numbers with respect to therapeutic hypothermia. First of all, the number needed to treat to save 1 life is 7, meaning that we need to chill 7 survivors of cardiac arrest to save 1 life. Furthermore, the number needed to treat to prevent 1 bad or poor neurologic outcome is only 5. These statistics highlight how significant and how important induced hypothermia is. Induced hypothermia is actually a relatively easy intervention to develop using chilled saline somewhere in the range of 0 to 4 degrees centigrade 2 liters are administered as rapidly as possible, and cooling blankets are used. Certainly more expensive and more complex machines and catheters are available for use and likely make it easier to reach the target temperature of 32 to 34 degrees centigrade, but thus far these machines have not been associated with improved outcome. Thus, at this time, it is still very appropriate to use cooling blankets and chilled saline in those patients that you feel should be chilled after cardiac arrest. I wanted to mention a relatively recent study that was published in the New England Journal looking at the target temperature in those patients resuscitated from out-of-hospital cardiac arrest. In this study of 950 patients who have been resuscitated, they were separated into 2 categories of target temperature for therapeutic hypothermia. The first group was 33 degrees centigrade compared to the second group of 36 degrees centigrade. No additional benefit was noted at the lower temperature level, which suggests that the target temperature is somewhere in the 32 to 36 degrees centigrade range. I personally aim for 34 degrees centigrade as my target temperature when I am using induced or therapeutic hypothermia in the resuscitated cardiac arrest patient. Recent discussion has focused on the use of therapeutic hypothermia during resuscitation. In this setting, patients who remain in cardiac arrest are actually treated with rapid infusion of 2 liters of chilled saline, chilled to 4 degrees centigrade. This is performed while chest compressions, defibrillation, airway management, and medication administration are also being performed. Limited evidence thus far suggests that it is a benefit, but remember, do not allow the basic important interventions to be interrupted or negatively impacted by this intervention. At this point, I am not using this intervention, and I am awaiting more information from clinical trials that are ongoing. Any discussion of induced hypothermia should include a brief mention of the appropriate candidates. The current literature and guideline statements address 5 areas, including the nature of the event, the location of the arrest, has the patient been resuscitated, what is the patient's mental status, and what was the initial cardiac arrest rhythm. Most definitely, cardiac-based or cardiogenic cardiac arrest events are the most appropriate entities that should be considered for hypothermia. These include STEMI and other cardiac-based cardiac arrhythmias resulting in cardiac arrest. But there are other situations where a sudden significant event has produced cardiac arrest, and once addressed and fixed, the patient is left only with the sequelae of cardiac arrest. Examples of these types of patients include a patient that has been electrocuted, experiencing cardiac arrest, or a patient that has experienced complete airway obstruction and cardiac arrest. These patients and others like them have experienced a sudden bad event producing cardiac arrest. Once the event has been stopped and the patient has been resuscitated, they are only left with the sequelae of cardiac arrest and likely could benefit from therapeutic hypothermia. The opposite end of the patient spectrum includes patients that have experienced significant events that have caused arrest and, if resuscitated, have significant ongoing pathophysiology related not only to the causative syndrome producing cardiac arrest, but also the sequelae of the post-cardiac arrest syndrome. Examples of these types of patients include patients with sepsis and multi-organ failure, patients with multi-drug overdose, multiple trauma, or patients with significant stroke or CNS hemorrhage. These types of patients and others likely do not benefit from therapeutic hypothermia and should not be chilled after resuscitation. The original studies addressed the out-of-hospital patient and suggested that these were the types of patients that should be chilled if resuscitated. Appropriate extrapolations have been made to the in-hospital patient, such that in-hospital patients who meet the other criteria can be considered for hypothermia. In most cases, therapeutic hypothermia is not appropriately applied to the patient who has not yet been resuscitated. As we noted in a previous slide, there are ongoing studies looking at the impact of the use of therapeutic hypothermia during resuscitation. While these early results are promising, the ultimate conclusion has not yet been provided. I would suggest we watch this closely before we decide to chill patients during resuscitation on a large scale. Most definitely, the patient that has been resuscitated and remains unresponsive is the type of patient we should consider chilling. We most definitely do not want to provide therapeutic hypothermia to a patient that is awake and alert. Not only do they not benefit from the chilling, but it also makes them significantly uncomfortable, resulting in an angry patient. And last, we've noted that the initial rhythms of VT and VF are the most appropriate initial rhythm candidates, although people have appropriately extrapolated this to include asystole and the various PEA presentations. The basic message in deciding who should be chilled and who should not be chilled should focus on the causative syndrome, looking at sudden significant events that are cardiac and non-cardiac based versus sudden significant events that are ongoing. The first group are appropriate candidates. The second group are likely not appropriate candidates. One other area of post-resuscitation care includes immediate coronary reperfusion or revascularization. In patients that have been resuscitated from cardiac arrest who are experiencing STEMI, the recommendations are rather clear-cut, suggesting that these patients should undergo some form of coronary reperfusion, either in the cardiac catheterization laboratory with a cardiologist or using a fibrinolytic agent, assuming there are no other contraindications. This concept has been extended to other patients that are experiencing ACS events but do not demonstrate ST elevation on their electrocardiogram. This is a controversial area of resuscitation science and cardiology management, which is further being explored. In this study that I've chosen to mention to you by Dumas and colleagues in Paris, 714 survivors of out-of-hospital cardiac arrest were retrospectively reviewed. Of these 714 survivors, 235 were excluded for obvious non-cardiac cause of the event, leaving 435 patients that went to cardiac catheterization. Approximately a third of these patients had ST elevation on their electrocardiogram. 74% of them underwent PCI with a 54% survival rate. Interestingly, 2/3 of the group that went to cardiac catheterization did not demonstrate significant ST elevation on their post-resuscitation 12-lead electrocardiogram. This group had an even higher rate of PCI performance. 88% of these patients underwent some form of percutaneous coronary intervention with a survival rate of 47%. This is an important area that we need to watch closely and monitor. The most appropriate candidates for coronary reperfusion are still being identified. At the present time, STEMI and other obvious ACS events likely should be chilled, and we may see the guidelines including other patients who do not demonstrate significant ST segment change also going to the cath lab urgently. It is also important to note that patients can be chilled with initiation of therapeutic hypothermia while coronary reperfusion is ongoing in the cardiac catheterization laboratory. If the clinician is able to identify the cause of cardiac arrest and tailor the therapy, outcome can be improved. However, the ability to identify the cause of cardiac arrest and separate cardiogenic from non-cardiogenic cardiac arrest early in the management phase of the patient is extremely difficult. For instance, Dumas and colleagues attempted to develop a prediction model which they could use at the bedside of a patient in cardiac arrest using limited clinical information. Their goal was to identify non-cardiac causes of cardiac arrest and potentially tailor their therapy. Unfortunately, they were unable to develop a prediction model that had any degree of accuracy. Even though it is difficult to identify the cause of non-cardiogenic cardiac arrest, when it is accomplished, it can improve the survival. In this study, we note that a survival rate of 32% is seen in patients with an identifiable and treatable cause of cardiac arrest, compared to 11% without an identifiable cause. These patients tend to present with pulseless electrical activity and have a range of triggers that are possible. So any intervention, any tool, any information that we can obtain that helps us identify the cause of cardiac arrest, particularly in the non-cardiogenic category, has the potential to improve outcome in the management of our patients with cardiac arrest. The use of end-tidal CO2 monitoring can in fact help us identify non-cardiac causes of cardiac arrest, regardless of the patient's cardiac arrest rhythm. We already know that end-tidal CO2 monitoring in cardiac arrest management is helpful in many ways, including confirmation of appropriate placement of the endotracheal tube, the adequacy of resuscitation, the suggestion of impending return of spontaneous circulation, prognostication, and several other important areas. A paper has suggested that we can also use end-tidal CO2 monitoring to differentiate cardiac-based from non-cardiac-based cardiac arrest. If we're able to identify these two subgroups, we potentially can tailor our therapy, and as suggested by prior work, particularly in the PEA presentation, tailored therapy can improve our rate of resuscitation in these very ill patients. Yet another application of end-tidal CO2 monitoring during cardiac arrest would allow us potentially to identify the return of spontaneous circulation while chest compressions are ongoing. It is certainly not inappropriate to continue chest compressions once a pulse has been determined, because in many cases these patients are experiencing a low flow state and do benefit from the augmentation of cardiac output produced by chest compressions. But most importantly, if we can monitor end-tidal CO2 production during active chest compressions and monitor sudden increases, which suggest the development of a pulse, that allows us to remove yet another interruption in chest compressions and the negative impact of interruptions associated with chest compressions. In a small EMS study of 108 patients, continuous end-tidal CO2 monitoring was performed via the endotracheal tube. Survivors demonstrated abrupt increase immediately prior to the return of spontaneous circulation, meaning that the end-tidal value suddenly increased at this time. These investigators suggested that this sudden increase in the end-tidal CO2 value was associated with the return of spontaneous circulation and the development of a pulse. And they could continue compressions without pulse check until further increases in the end-tidal CO2 value. This is a very interesting area of resuscitation medicine that again would allow us to continue compressions without interruption. I very much appreciate your attention during this lecture and hope that a recorded lecture is of some value to you in learning about cardiac arrest management. My email address is depicted below on this slide. Please do not hesitate to contact me if you have any questions or comments about anything I've said or anything else regarding cardiac arrest management. One day soon, I hope to visit your beautiful country and meet all of you. Please enjoy your day, and I thank you for your time.